Welcome to the new iWorld Live studio, and thank you for participating in this live event. I'm here with Kevin Miller. Kevin, we're going to be talking about some interesting things. Did I say interesting? I meant frightening things. We're going to be talking about vitrectomy techniques. Now, I have to tell you that I share the anxiety that a lot of our membership, I'm sure, does. When people start talking about the relative advantages of doing pars plana vit, that's just not a set of techniques that I'm particularly used to doing. Let me start out by asking, is anterior vitrectomy a good enough technique?
It can be, depending on how you do it. So with anything, there's a good way and there's a bad way of doing it. So you never want to do a Weck-cell sponge vitrectomy, for instance. You never want to tug on the vitreous. You always want to separate the aspiration and infusion lines for 1,000 reasons, but that's always good technique. And you can do a very excellent vitrectomy through a limbal approach with some nuances, and so the primary one is we don't want to be irrigating the endothelium, so you want to keep your irrigation a little bit low, but you don't want to be pulling vitreous up, especially if you're doing the vitrectomy probably in the most common setting that our membership would be doing it, which is capsule rupture during cataract surgery. You don't want to take what may be a relatively small hole and make it bigger by dragging vitreous up, enlarging the hole, and then tugging on the vitreous. So you can do an anterior vitrectomy without doing that, right? And you can also do a pars plana vitrectomy without doing that.
So, talk to me about the advantages. You've alluded to them of a pars plana vit. Make the case for why it is worthwhile for me to go that route, and then maybe you can act as a therapist here and help me with my anxiety.
Yeah. So the primary advantages of the pars plana vitrectomy is that it puts the aspiration cutting port into the vitreous cavity. So rather than bringing things up, you're bringing things down. You're bringing it out of the anterior chamber, and you're preserving the opening that you've already inadvertently made in the posterior capsule, not enlarging it. So that's actually huge because you want to preserve capsule. In many of our cataract cases gone wrong, we can actually get a lens in the back. I just did it this week. I popped a hole in the capsule trying to get subincisional cortex. I immediately put visco agent in, and I was able to put a lens in the bag, despite a relatively bad complication. So by going through the pars plana, you bring the vitreous back. And it's really as simple as that. You're already separating the infusion and the aspiration lines. So by separating them in space, by putting one in the vitreous cavity, you're just going to maintain the vitreous in the vitreous cavity.
So what are good first cases? I don't think. Correct me if I'm wrong. A topical case in which I've ruptured capsule or a dialysis of the zonules, and already my anxiety is high because of that. It is a good first case for me to start doing pars plana. But how should I start out?
You're absolutely right. So the ideal first case is blocked. It's controlled because of that. Patient's not going to feel it when you do the sclerotomy. So I think an ideal first case would be like a lens exchange case, or maybe a complicated cataract case where you just don't feel you can do it under topical. You're going to do a block anyway, just for a cataract case. It's a block case because doing that sclerotomy is uncomfortable. It hurts. And if you're doing it in a squishy eye situation, which is going to be the case if you're doing it in cataract surgery and you break capsule, squishy eyes and topical anesthesia don't really go well together for getting the sclerotomy done. So I would say if you're going to plan it, do a lens exchange eye. You have a firm globe, you make your sclerotomy early, and it'll be pressurized, and you'll get in. And you just have to make sure you're measuring the appropriate distance. Maybe it depends if it's a pseudophakic guy, maybe 2.5 millimeters posterior to the limbus is appropriate. Aim towards the optic nerve. Don't aim towards the lens. So and now you've got a hole in the eye, and you don't have to jump to using trocars and all the fancy stuff that the vit people do. Just a single stab, and that's big enough for your particular vitrector. That's key. Make sure it's not too small, and you're trying to jam the vitrector into a hole that's too small.
Yeah, no, that's a great point, and I assume that it may be worth my while now to spend a little quality time with my vitreoretinal colleagues and watch them do cases?
Perhaps, or just go to a pig lab. You can get one of Stuart Stoll's model eyes and practice. I mean, there's 1,000 ways. You can take one of the ASCRS labs. We have some excellent anterior vitrectomy labs and phaco labs where you could practice that. But it's not difficult. It's more of a mental hurdle than it is a physical technique hurdle. Once you get the hole and you get the vitrector in the eye, it's done. That's the surgery. Just the rest of it, just taking out the vitreous now.
Yeah. Well, this is helpful stuff, and as we always say, I mean, we hope for the best, but we plan for the
That's
worst.
right.
Kevin, I want to thank you for bringing this frankly upsetting topic to us, and for making it clear and in a way that I think that I can probably live with. And I want to thank you, as always, for being so very generous with your time with us today. And I want to thank you, our live audience, for sharing this event with us in the new iWorld studio.